Today is about metabolic response to injury. The graded nature of the injury response, it is important to recognize that the response to injury is graded. The more severe the injury, the greater the response. This concept not only applies to physiological and metabolic changes, but also to immunological changes or sequelae. Thus, following elective surgery of intermediate severity, there may be a transient and modest rise in temperature, heart rate, respiratory rate, energy expenditure, and peripheral white cell count. Only major trauma or sepsis, these changes are accentuated, resulting in a systemic inflammatory response, hypermetabolism, marked catabolism, shock, and even multiple organ dysfunction. يعني مو كل response to injury يكون في level معين، ممكن يكون high level أو ممكن low level، ممكن إنه يكون just increase in temperature، ممكن just increase in heart rate، or قد يصل إلى multiple organ dysfunction. Not only is the metabolic response graded, but it also evolves with time. يعني ممكن إنه يبدي mild increase in temperature مثل ما ذكرنا، heart rate or respiratory rate، وبعدين يصير progression إلى أن يوصل ممكن إلى shock or even multiple organ dysfunction. In particular, the immunological sequelae of major injury evolve from a pro-inflammatory state driven primarily by the innate immune system, لأن المicrophages, neutrophils, dendritic cells, into a compensatory anti-inflammatory response syndrome, characterized by suppressed immunity and diminished resistance to infection. In patients who develop infective complications, the latter will drive ongoing systemic inflammation, the acute phase response, and continued catabolism. واضح يمكن؟ واضح الصوت يمكن؟
اي دكتور واضح.
Okay. Mediators of the metabolic response to injury. The classical endocrine pathways of the stress response consist of afferent nociceptive neurons, spinal cord, thalamus, hypothalamus, and pituitary. Corticotropin releasing hormone released from hypothalamus increases adrenal corticotropic hormone اللي هو ACTH. يعني ان الهايبوثالاموس اللي تفرز ان الكورتيكوتروبين ريليزنج هرمون هذه مسيطرة على البيتوتري حتى تفرز لنا الاي سي تي اتش او الادرينال كورتيكوتروبيك هرمون which is released from anterior pituitary. ACTH then acts on the adrenal to increase the secretion of cortisol. Hypothalamic activation of sympathetic nervous system causes release of adrenaline and also stimulates release of glucagon. Intravenous infusion of a cocktail of these counter-regulatory hormones اللي هن glucagon, glucocorticoids and catecholamines reproduces many aspects of the metabolic response to injury. There are many other players include يعني حسب metabolic response to injury. السي العفو الكورتيكوتروفين ريليزنج هرمون اي سي تي اتش ادرينالين جلوكاجون فقط لا مو بس ان الانسولين والبرولاكتين والثايرويد هرمونز also play a role. تمام. هذا مخطط تقريبا يفصل لنا الميتابوليك ريسبونس والهرمونز اللي ممكن تنفرز during وايضا السيتوكينز اللي involved in systemic metabolic response to injury. Immune system, principally macrophages, interacts in a complex manner with the adaptive immune system, T cells and B cells, in co-generating the metabolic response to injury. Pro-inflammatory cytokines, including interleukin-1, tumor necrosis factor alpha, interleukin-6 and 8, are produced within the first 24 hours and act directly on the hypothalamus to cause hypyrexia. Such cytokines also augment the hypothalamic stress response and act directly on skeletal muscle to induce proteolysis while inducing acute phase protein production. Other important pro-inflammatory mediators include nitric oxide via inducible nitric oxide synthase and a variety of prostanoids via cyclooxygenase or يسموه COX-2. Changes in organ function, example renal hypoperfusion impairment may be induced by excessive vasoconstriction via endocrine factors such as endothelin-1. There are many complex interactions between the neuroendocrine cytokines and metabolic axes. يعني كل اكس من هذه الباثويز يعني مو كل واحد على حده، اكو تداخل بيناتهم، ما يصير كل واحد وحده. Although cortisol is immune suppressive at high levels, it acts synergistically with interleukin-6 to promote the hepatic acute phase response. ACTH release is enhanced by pro-inflammatory cytokines and the noradrenergic system. نبذة تاريخية عن ال ebb and flow phase metabolic stress response to surgery and trauma. نوضع هذا المخطط تقريبا سنة 1930 باي سير ديفيد. قسم لنا ال metabolic response to surgery or to injury into ebb phase, flow phase and recovery phase. كل واحد منهم حسب قد الوقت اللي استغرقه الأونست مالته وشنو اللي يصير عندنا بالجسم. If phase begins at the time of injury and lasts for approximately 24 to 48 hours. It may be attenuated by proper resuscitation, but not completely abolished. ممكن إنه proper resuscitation يقلل لك ال F phase، لكن ما راح تقدر، مستحيل تقدر إنه تنهي أبدا. The F phase is characterized by hypovolemia, decreased basal metabolic rate, reduced cardiac output, hypothermia, and lactic acidosis. The prominent hormones regulating the F phase are catecholamines, cortisol, and aldosterone, following activation of the renin-angiotensin system. The magnitude of this neuroendocrine response depends on the degree of blood loss and the stimulation of somatic efferent nerves at the site of injury. Main physiological role of the phase is to conserve both circulating volume and energy stores for recovery and repair. Following resuscitation, the phase evolves into a hypermetabolic or flow phase, which corresponds to systemic inflammatory response to surgery. This phase involves the metabolization of body energy stores for recovery and repair, and the subsequent replacement of lost or damaged tissue. Flow phase is characterized by tissue edema from vasodilatation and increased capillary leakage, increased basal metabolic rate, hypermetabolism, increased cardiac output, rise body temperature, leukocytosis, increased oxygen consumption, and increased gluconeogenesis. The flow phase may be subdivided into initial catabolic phase, which lasting for 3 to 10 days, followed by anabolic phase, which may last for weeks if extensive recovery and repair are required following serious injury. During the catabolic phase, the increased production of counter-regulatory hormones, including catecholamines, cortisol, insulin, and glucagon, and inflammatory cytokines, example, interleukin-1, 6, and tumor necrosis factor, results in significant fat and protein mobilization, leading to significant weight loss and increased urinary nitrogen excretion. A combination of pronounced or prolonged catabolism in association with insulin resistance places patients within this phase at increased risk of complications, particularly infectious and cardiovascular. هذا الفيس يكون الجسم شوي مرحلة ضعف، فممكن إنه تزيد الكومبليكيشنز أو تظهر عندنا complications خاصة infectious و cardiovascular، اللي هي طبعا just infection أكثر شيء و UTI. Catabolic elements of the flow phase of the metabolic stress response. The essence of this coordinated response is to allow the body to reprioritize limited resources away from peripheral tissues, muscle, adipose tissue, skin, and towards the key visceral liver, immune system, and the wound. First, hypermetabolism. The majority of trauma patients, except possibly those with extensive burns, demonstrate energy expenditures approximately 15 to 25% above predicted healthy resting values. Second, alterations in skeletal muscle protein metabolism. Muscle protein is continually synthesized and broken down with a turnover rate in humans of 1 to 2% per day, and with a greater amplitude of changes in protein synthesis. During the catabolic phase of the stress response, muscle wasting occurs as a result of an increase in muscle protein degradation. The enzymatic pathways coupled with a decrease in muscle protein synthesis. The major site of protein loss is peripheral skeletal muscle. Although nitrogen losses also occur in the respiratory muscles, predisposing the patient to hypoventilation and chest infections, and in the gut, reducing gut mobility occur areas. Cardiac muscles appears to be mostly spared. ما مشمول الكاردياك muscle بهذه breakdown. Under extreme conditions of catabolism, example major sepsis, urine nitrogen losses can reach 14 to 20 grams per day. This is equivalent to the loss of 500 grams of skeletal muscle per day. Clinically, a patient with skeletal muscle wasting will experience asthenia, increased fatigue, reduced functional ability, decrease the quality of life, and increase the risk of morbidity and mortality. نحاول بإمكان أن المريض ما نخليه يوصل إلى muscle wasting و try to compensate this response. Alterations in hepatic protein metabolism, the acute phase protein response, the liver and skeletal muscle together account for more than 50% of daily body protein turnover. Skeletal muscle has a large mass, but a low turnover rate, 1 to 2% per day, whereas the liver has a relatively small mass, 1.5 kilogram, but a much higher protein turnover rate يوصل إلى 10 إلى 20% per day. In response to inflammatory conditions including surgery, trauma, sepsis, cancer, or autoimmune conditions, circulating peripheral blood non-nuclear cells secrete a range of pro-inflammatory cytokines, including interleukin-1, 6 necrosis factor. These cytokines, in particular interleukin-6, promote the hepatic synthesis of positive acute phase proteins, for example, fibrinogen and C-reactive protein. In contrast to the positive acute phase reactants, the plasma concentrations of other liver export proteins, the negative acute phase reactants, fall acutely following injury, example, albumin. Insulin resistance. Following surgery or trauma, postoperative hyperglycemia develops as a result of increased glucose production combined with decreased glucose uptake in peripheral tissues. Decreased glucose uptake is a result of insulin resistance, which is transiently induced within the stressed patient. Post-operative patients with insulin resistance behave in a similar manner to individuals with type 2 diabetes. The mainstay of management of insulin resistance is intravenous insulin infusion. لكن شوف إنه بعض الأحيان post-operative patients or post-trauma patients شوف عندهم هايبرغلايسيميا، مريض هو اصلا نون دايابيتك او ممكن انه يكون دايابيتك with controlled DM. Insulin infusions may be used in either an intensive approach, that is say sliding scales are manipulated to normalize the blood glucose level, or a conservative approach, which means insulin is administered when the blood glucose level exceeds a defined limit and discontinued when the level falls. Avoidable factors that compound the response to injury. Continuing hemorrhage, hypothermia, tissue edema, tissue under perfusion, starvation, and immobility. لأن يكونهم ممكن إنه نتجنبهم حتى avoid يصير عندنا avoidance لل progression of systemic inflammatory response. Volume loss. During simple hemorrhage, receptors اللي يسموهم baroreceptors in the carotid artery and aortic arch and volume receptors in the wall of the left atrium initiate afferent nerve input to the central nervous system, resulting in the release of both aldosterone and antidiuretic hormone. Pain can also stimulate antidiuretic hormone release. Antidiuretic hormone acts directly on the kidney to cause fluid retention, decreased pulse pressure, stimulates the juxtaglomerular apparatus in the kidney, and directly activates the renin-angiotensin system, which in turn increases aldosterone release. Aldosterone causes the renal tubule to reabsorb sodium and subsequently also conserve water. ACTH release also augments the aldosterone response. The net effects of antidiuretic hormone and aldosterone results in natural oliguria observed after surgery. Hypothermia. Hypothermia results in increased elaboration of adrenal steroids and catecholamines when compared with normothermic control. Even mild hypothermia results in 2 to 3-fold increase in postoperative cardiac arrhythmias and increased catabolism. Maintaining normothermy by an upper body forced air heating cover reduces wound infections, cardiac complications, and bleeding and transfusion requirement. Tissue edema. During systemic inflammation, fluid, plasma proteins, leukocytes, macrophages, and electrolytes leave the vascular space and accumulate in the tissues. This can diminish the alveolar diffusion of oxygen and may lead to reduced renal function. Vasodilatation implies that intravascular volume decreases, which induces shock if inadequate resuscitation is not undertaken. Meanwhile, intracellular volume decreases, and this provides part of volume necessary to replenish intravascular and extracellular volume. Systemic inflammation and tissue under perfusion. The vascular endothelium controls vasomotor tone and microvascular flow and regulates trafficking of nutrients and biologically active molecules. When endothelial activation is excessive, compromised microcirculation and subsequent cellular hypoxia contribute to the risk of organ failure. Maintaining normoglycemia with insulin infusion during critical illness has been proposed to protect the endothelium. Starvation. During starvation, the body is faced with an obligate need to generate glucose to sustain cerebral energy metabolism, 100 grams of glucose per day. This is achieved in the first 24 hours by mobilizing glycogen stores and thereafter by hepatic gluconeogenesis from amino acids, glycerol, and lactate. The energy metabolism of other tissues is sustained by mobilizing fat from adipose tissue. Immobility. Mobility has long been recognized as a potent stimulant for inducing muscle wasting. Inactivity impairs the normal meal-derived amino acid stimulation of protein synthesis in skeletal muscle. Avoidance of unnecessary bed rest and active early mobilization are essential measures to avoid muscle wasting. Thank you. Any questions?